All right, so next up we have hypertrophic cardiomyopathy, or HCM, and it's generally LV or RV hypertrophy of various morphologies, plus minus LVOT, dynamic obstruction. The difference between HCM and HOCM being that LVOT, dynamic obstruction, characterized also by diastolic dysfunction, MR, and high risk of arrhythmia or sudden cardiac death. And exam usually showing a murmur that augments with Valsalva standing. So essentially, it's the opposite of aortic stenosis due to decreased preload. So diagnosis, ECG showing a large Q wave in inferior lateral leads, and on echo showing unexplained LVH and plus minus outflow tract gradient. And cardiac MRI, it's a pretty good diagnostic for underlying etiology of hypertrophic cardiomyopathy. Sometimes you can see fibrosis, and some patients, especially younger patients, it's important to get genetic testing, and mutations are present in about 70% of individuals, and also, of course, helpful to screen for family history. Treatment, essentially to avoid volume depletion, especially if there is HOCM or Hocm, and also avoid high-dose vasodilators. If patients in shock, phenylephrine is pressor of choice. If no response to IV fluid, essentially increases afterload and stents open the LVOT. Activity restriction, beta blockers are greater in efficacy than calcium channel blockers like verapamil, ditizem, septal ablation or surgical myectomy for medically refractory symptoms, and ICD as well if they have risk factors like prior VT, sudden cardiac death, or unexplained syncope, family history of sudden cardiac death in first degree relative, if they have massive LVH greater than 3 centimeters, non-sustained ventricular tachycardia on Holter monitor. Essentially, all of these causes, so they have prior VT, sudden cardiac death, unexplained syncope, or family history of sudden cardiac death in first degree relative, is the indication for an ICD. Next up, we'll be talking about restrictive cardiomyopathy and their underlying etiologies as well.